DeBakey Lecture in Medical Humanities and Bioethics. And fantastic to have you all here, especially right before the holiday coming up. We know this is a topic of great interest, and we're very excited about presenting Dr. Hotez and Dr. Stahl today. Just a word about the named lecture here. The DeBakey Foundation has been one of the most important patrons that the Medical Humanities program at Baylor University could ever want to have. Most of you will know that Dr. DeBakey was a pioneering cardiovascular surgeon, and he had a career that spanned over 75 years and lived out his own personal standard of excellence. The New York Times asked surgery residents, if you were on the operating table, would you want a perfectionist or somebody who cared little for detail? That's what he asked his surgical residents, and he always insisted on excellence. He performed surgery over more than 60,000 patients, from world leaders and celebrities to common citizens. And his sisters, Lois and Selma, were very important in his life and were also pioneers in their own right in the field of communication between doctors and patients. And so to have the DeBakey Foundation support for the Medical Humanities program has been crucial. We're delighted today to have both Dr. Peter Hotez and Dr. Devan Stahl with us. I'm going to first introduce Dr. Hotez, and the way this will work, I want to let you all know that the session is being recorded, and let you know that you can enter questions in the chat. If we have time, we'll take questions as much as we can. First, I'm going to introduce Dr. Hotez, and he is going to have about 20 minutes of remarks from his perspective, and then Dr. Devan Stahl will be responding in the second 20 minutes, and for the rest of the time, what I hope to happen is to watch a dialogue between Dr. Hotez and Dr. Stahl with questions supplied by the audience as we're able. So let me first introduce Dr. Hotez, who is, as many of you know, an American scientist, pediatrician, and advocate in the field of global health and vaccinology, not to mention, of course, neglected tropical diseases. He's the founding dean of the National School of Tropical Medicine and professor of pediatrics and molecular virology and microbiology at Baylor College of Medicine, where he's also director of the Texas Children's Hospital Center for Vaccine Development and the Texas Children's Hospital Endowed Chair in Tropical Pediatrics. He's a university professor at Baylor University, where we're delighted to have his affiliation. And you all have probably seen him all over all kinds of media. And I could go on and on with his introduction, but I want to leave plenty of time for his remarks. Dr. Hotez, we really appreciate you being with us today, and leave it to you to begin our afternoon together.
Well, thanks very much, Professor Barron, and it's great to be with Professor Stahl as well, and looking forward to a very interesting discussion. I don't know that I need to talk 20 minutes. I'd rather have more time for back and forth and discussion. I'll just make a few broad remarks on where I see things heading right now with COVID-19. So as many know, I'm a vaccine scientist and an MD PhD vaccine scientist working on vaccines for parasitic diseases, which I've spoken many times to here at Baylor University. But then about 10 years ago, we adopted a coronavirus vaccine program. I say we, the Texas Children's Center for Vaccine Development is co-headed by myself and Mary Elena Bottazzi, who's also a professor at Baylor University. And we adopted a coronavirus vaccine program 10 years ago because they were orphaned like parasitic diseases, disease vaccines, because nobody cared about coronavirus vaccines 10 years ago. And then something changed in January 2020, and we were able to pivot our program to start developing COVID-19 vaccines. And now we have a low-cost recombinant protein COVID vaccine that hopefully should be released for emergency use authorization maybe as early as next week or the end of the month, maybe first week in December. So that's really exciting because we think this could be the vaccine to really help close the gap on vaccinating the Southern Hemisphere. So it's going to be, it was licensed both into India, Indonesia, and Bangladesh. India's furthest along, and we hope that soon we can fill this gap, because right now the difference between the global north and the south is huge, and it's devastating. Anyway, in the United States, where we were coming down pretty regularly. And unfortunately, in the last 2 weeks, the cases are up again another 25%, and 14% just in the last week. So it looks as though we're going to hit over 100,000 cases yet again. So while the epidemic has been declining in Texas, it's now going back up, mostly initially in the upper Midwest, Michigan, Wisconsin, Minnesota, just like last year. So if you remember last year, we had a terrible summer wave across Texas and the South, and then it died down around October, November, and then it picked up again after Thanksgiving, starting in the Midwest, upper Midwest, before it hit Texas yet again. And it looks like that's what's happening, unfortunately, because there's just too many unvaccinated Texans and too many unvaccinated Americans. So only about 40% of the country is still unvaccinated. So this Delta variant is so aggressive; it's just sweeping through those populations. For me, I think the devastation in Texas is particularly awful. The number of deaths in the state of Texas is about to eclipse California. Maybe even today it eclipsed California as the worst affected state in the country in terms of total number of deaths. We're at about 75,000 deaths, and we could get to 80,000 deaths before the end of the year. So this, without question, is probably the greatest single human tragedy that's ever affected the state of Texas. I'm particularly upset about the last 20,000 deaths, because those last 20,000 deaths, 85 to 86% of them were among the unvaccinated after June 1, despite the widespread availability of vaccines. So these are individuals who did not have to lose their lives. These are individuals who chose not to get vaccinated because they were victims of all of this disinformation or misinformation, or what I actually call anti-science aggression. So if you think about it, that's quite amazing. 20,000 Texans who chose not to get vaccinated lost their lives as a consequence of that. And I think that will haunt our state for years to come. I don't even know what words to describe it anymore. It's the greatest self-immolation, or practically mass suicide, that we've ever experienced in the state of Texas by orders of magnitude. um, and people who erroneously believe that ivermectin was an appropriate substitute when there was never evidence that it was very effective at all, and refusing to get vaccinated. And I think, maybe in our discussion we could talk a little bit about how the anti-vaccine, anti-science movement accelerated so much during these years of COVID. I've spoken at Baylor University a couple of times explaining how the anti-vaccine movement originally was focused around fake beliefs that vaccines cause autism, but then it took on a political dimension starting around 2014, 2015, under this phony banner of health freedom, medical freedom, that basically said, we can do what we want with our kids, and that caused 70,000 kids to get denied access to their vaccinations. And then during this time of COVID, those same protests under a banner that they called health freedom or medical freedom expanded, and starting in 2014, the anti-vaccine movement became a political movement. It very much linked to the Republican Party, the Tea Party, the far right end of the Republican Party, under this mantra banner, health freedom, medical freedom. And that's what's with us today. And I think as a physician scientist, and I'd be curious to hear what Devan has to say about this, I think this is the hardest thing for us to talk about, because all of our training, right, says, well, we don't talk about Republicans and Democrats and liberals and conservatives. We're scientists. We're supposed to, not lapse into politics. But, it's not individuals like myself who politicize vaccines. It's those guys who did it. And I think it's our job to find a way to uncouple the anti-science and anti-vaccine aggression out of the out of the politics. And I've not found a way to talk about it other than to talk about it. And I think we should be useful to have some discussion about how you go about doing this, because it's all about saving lives. And again, I keep on hammering home that number: 20,000 needless deaths of victims of this anti-science aggression from far-right extremism, which is here in Texas. So Texas is the center of the US anti-vaccine movement. And I would argue now that the anti-vaccine movement is being exported globally into Western Europe, the Nordic countries, England, into Canada now. Texas, especially Central Texas, is the epicenter of the global anti-vaccine movement, and the place where it first became politicized, linked to far right-wing extremism, and now causing massive loss of life. And one of the reasons I'm talking about it, for instance, I was just on CNN earlier today, and I said one of the reasons I'm talking about it in such an open way is we're not out of this by any means. With this next winter wave about to hit the upper Midwest, what's going to happen? I mean, we still have 40% of the country unvaccinated, and thousands who will likely become defiant of vaccines in the winter, just as Texans were defiant of vaccines in the summer. So we'll continue to accelerate to enormous losses in life. And I think we could get to 800,000 American deaths by next year. And some of the forecasts say that we could even get to 1 million deaths by the first quarter of 2022. That's how dire things could get. And again, because of this defiance around vaccines, or tying one's political allegiance to this very self-defeating notion of health freedom, to the point where people are not going to get vaccinated. And you're hearing it from celebrities, right? We heard it from Aaron Rodgers of the Green Bay Packers, who says he's a critical thinker. He's not. He's just bought. He's taken it, hook, line, and sinker, as they say. All of the talking points coming out of the political aggression of the right, with health freedom, my body, my choice around vaccines. It's all garbage, right? And it's a killer. And so right now, anti-science aggression, from what I can tell, is now the leading killer of young adults in the United States, and mostly led in Texas, but that's going to continue to accelerate in the upper Midwest. So, my feeling is, if you're a physician or physician scientist and you're really committed to saving lives, we have to talk about it, and we have to find a way to diffuse it or counteract it. And my opinion is that the health sector is sort of doesn't know what to do about this. And we're hearing from the U.S. Surgeon General, who's talking about the social media companies and the role of Facebook and other social media platforms. And I get that it is a device used to disseminate a lot of the information, but it's not getting to the source, where we have members of the U.S. Congress now openly saying that first they're gonna vaccinate you, and then they're gonna take your guns and Bibles away. And as ridiculous as that sounds to everybody here, there's a good percentage of the country that believes it, or that vaccines are political instruments of control. And that kind of discussion is absolutely deadly. And we just had Marjorie Taylor Greene yesterday compare people who vaccinate us to, she calls them brown shirts, a lot of Nazi metaphors, and even calls them vaccine Nazis. And that's how, so they like the far right loves its use of Nazi imagery, which of course is so offensive to so many people. So this is a dark time in our country, and it is leading to an extraordinary level of human life lost. And so I hope we can explore today in this hour what we can do about it. And Lauren, I would say this is also a reminder of why something like the medical humanities is so vital for us, right? Because we don't, this is not a typical discussion you would have in a Department of Molecular Virology and Microbiology here at Baylor College of Medicine. People don't have the skill set or the tools or the background to know how to have this kind of discussion. And this is why, when you invited me to talk, I was so thrilled, because this is exactly the sweet spot for medical humanities to deal with some of our most pressing issues. And we could go on, because the COVID-19 has exposed so many weaknesses in our healthcare infrastructure. I mean, the other topic that maybe we can touch on is this massive, people call it burnout. It's not quite the right word, of just nurses and healthcare providers and doctors abandoning the health professions in record numbers. I think they just cannot tolerate all the loss of life, and especially, our healthcare heroes who've worked in intensive care units these last 2 years, and particularly those who knowingly were defiant and lost their lives accordingly, and having buyer's remorse on their deathbed, realizing they should have gotten vaccinated. I think that's taken a huge toll also on our healthcare workforce. So we're seeing shortages all across the country, including, here in our Texas medical center as well. And how do we fix that? And I think that's going to be another vital role for the medical humanities. So I've said a lot. I'll take a break and see what my colleague, Professor Stahl, has to say.
Thank you so much, Dr. Hotez. It's my pleasure to introduce to everyone Dr. Devan Stahl. She's an assistant professor of religion here at Baylor University, and she has an extensive background in bioethics and clinical ethics, and she teaches theological bioethics, disability studies, beginning and end of life issues, medicine, and the visual arts. And she's a certified healthcare ethics consultant, working with hospitals locally in Waco. So she's not just in the classroom, but she's actually a part of ethics consulting clinically in the hospitals. And I also want to mention the bioethics initiative that we have here at Baylor, the Baylor Ethics Initiative. You can go to the website and check that out. And Dr. Stahl, in addition to all the other things she does, is the convener of the Bioethics Research Group. We now offer a certificate for our undergraduate students in bioethics, and she's in charge of all those things. And, but wait, there's more. She also has a podcast called Bioethics for the People, and she's got over 20,000 followers, and I just bet she might be able to talk Dr. Peter Hotez into being her guest one day. So I will ask you all to help me welcome Dr. Devan Stahl this afternoon. Devan?
Great, thanks, Lauren, and thanks, Dr. Hotez. I think we have a lot of intersecting points we want to make, so I'm sure we'll have a good discussion after this. Right, go back one. So I want to talk a little bit about the challenges that bioethicists have faced during this pandemic. So of course, the COVID-19 pandemic has raised a lot of bioethics issues over the last 20 months or so, some of which arose early and many of which are ongoing. So sometimes in bioethics, we joke that there's nothing new under the sun, and that may be true, but there were many issues that came up that really stretched bioethicists to consider topics that they were less familiar with, including how to write triage protocols or mass critical care guidelines that fairly distribute scarce resources, how to balance isolation measures with mental health needs, how to deal with increasing demands for unproven therapies or non-beneficial treatments, how to fairly distribute vaccines, and how to think about vaccine exemptions. And finally, as Peter Hotez was just mentioning, this unprecedented burnout or moral distress really of our healthcare providers. So one of the first challenges that arose came from these mass critical care guidelines. Now, most of the work that I do in bioethics is in hospitals, where I think mainly about the clinician-patient relationship. So thinking about bioethics from a public health perspective was a new orientation. How do we weigh patients' needs against one another in the event of scarce resources? Or how do we prioritize patients when the need for resources is greater than our supply? So before we had many treatments for COVID, we recognized that we might have more patients coming into the hospital than we had ventilators, ICU beds, ECMO machines, or medical staff to treat them. Hospitals needed to write protocols for how they were going to allocate those scarce resources. So most state public health departments had some guidance that dated back to 2009 after the H1N1 scare. The idea was that you should use objective criteria to try to save as many lives as possible. So you give scarce resources to patients who are most likely to survive and live a long life. What quickly became obvious, however, was that the guidelines were controversial. In particular, disability rights groups criticized the guidelines for being blatantly discriminatory toward disabled people. For example, some state guidelines said that people with intellectual disabilities should not be offered intensive care. So the Office of Civil Rights, which is the federal agency which enforces civil rights legislation, received several complaints from disability rights groups alleging that their state guidelines were not upholding ADA standards, including groups in Texas. And as a result, a lot of mass critical care guidelines were rewritten to ensure they weren't unfairly discriminating against people with disabilities, as well as the elderly. So some of the state protocols had age cutoffs for who would receive intensive care. So there's still some fear that from certain persons that discrimination could happen, but states and hospitals responded to these concerns rather quickly. We never had to trigger our mass critical care guidelines in Texas, but several states have across the country over the last year. So in addition to disability rights groups, other groups argued that those who experience significant health disparities should be given priority access to care during the pandemic. For example, we know that certain minority populations have less access to preventative medicine and have worse health outcomes because of systematic barriers to healthcare and other health-related goods. So some hospitals began to use an area deprivation index, or an ADI, which measures a geographic area's level of socioeconomic deprivation that's associated with health disparities. So in the case of a tiebreaker, where two patients are equally likely to survive their hospitalization with treatment, the patient who lives in an area where people experience more health disparities might get priority access to treatment. So this, of course, was controversial, and not every hospital added an ADI to its protocols. Most bioethicists agree that health disparities are a big problem in our country, but many didn't think that the pandemic was necessarily the best time to fix those disparities. And more recently, bioethicists have argued about whether it would be ethically acceptable to take vaccine status into consideration during triage. Now, part of this reasoning is that people who are vaccinated tend to experience less severe disease. But once patients need ventilators, those advantages might fall away. So the question then is there an ethical reason to prioritize the vaccinated? Perhaps because they at least tried to prevent hospitalization. In practice, however, I've not heard of any hospital that's actually using vaccine status as a measure for triage. And in fact, most of the medical team is not aware of the patient's vaccine status. And as Dr. Hotez mentioned, really what we're seeing in our ICUs right now is the unvaccinated. So early on in the pandemic, lockdowns became a source of contention as well. Curbing the spread of the virus is a serious issue, but at the same time, cutting people off from their friends and family placed many people in other kinds of jeopardy. So those who don't live in safe home environments were suddenly unable to leave, which might have put them at risk for increased domestic abuse. People with certain mental health conditions experienced increased stress and illness as a result of being cut off from their support systems. And people living in congregate care facilities or who were severely ill in hospitals were cut off from visitation. And this was perhaps most clear in nursing homes. Regular interaction with others is important for mental and physical well-being, especially for the ill and elderly. At the same time, COVID was moving through nursing homes very quickly, killing many residents. So many nursing homes stopped allowing visitors when family members were finally let back in. They saw a tremendous decline in their loved ones' physical and mental health. So balancing the risks of spreading disease with the risks of isolation is difficult, and it's still unclear that we did the right thing during lockdowns with no visitation policies. So one of the next challenges that hospitals faced was what to do with patients who requested experimental or unproven therapies when they got COVID, and Dr. Hotez was mentioning this. So you may remember that happened early on with hydroxychloroquine, which is not an antiviral and has considerable associated risks like heart abnormalities, severe liver inflammation, kidney failure. There was also some speculation that ingesting bleach might be beneficial, or that certain vitamins could ward off the effects of COVID. And more recently, we've seen a lot of patients demanding ivermectin, which is an antiparasitic that some people believe could help alleviate COVID-19. It also has side effects and no proven efficacy, and really can be extremely harmful when taken in large doses, or when people mistakenly took the version made for horses instead of humans. So recently, there's been lawsuits all over the country where patients have demanded access to ivermectin that physicians have refused them. And we've seen a couple of these lawsuits in Texas. So there's a conflict here, of course, between patient rights and professional obligations of beneficence and the commitment to do no harm. I'll just say briefly that typically patients don't have positive rights to treatment, only negative rights, not to be treated against their will, and so-called right to try laws regarding access to drugs that are still undergoing clinical research typically don't apply to patients who are requesting ivermectin. And of course, there have been many ethical issues related to the vaccine. So at first, it was how to distribute the vaccine fairly. Who should have access to the vaccine first, and why were they more deserving? Again, the vaccine was initially a scarce resource, so we had to decide who should get priority access. Should those who are most likely to contract the virus get the vaccine first, or those who would be most harmed by getting COVID? Are healthcare workers more deserving, and if so, why? And here, questions of risk, equity, and vulnerability were all in question. So the CDC advised that the order goes something like healthcare workers, because they're on the front lines fighting the pandemic and likely to contract the virus; those living in congregate care facilities, such as nursing homes, because they were vulnerable to contracting and dying of the disease; and then frontline essential workers who couldn't do their jobs remotely and were important for keeping the economy running; and then those in certain age brackets. First, it was 75 and then 60 to 74. I think in Texas, we just kind of went 75 and up at first. And then we did those with high-risk medical conditions, and then everybody else. So not all states followed the CDC guidelines, but the idea in general was to decrease death and serious disease, stop the spread of the virus, preserve the functioning of society, and reduce the extra burden of COVID-19 on people already facing disparities. Now, similar considerations are now in place for boosters, with the additional question of whether we should be sending more vaccines abroad to countries where very few people have been vaccinated and where new variants may arise that could find their way to our country. So we're now, of course, also seeing a lot of ethical dilemmas arise in regard to what to do with those who refuse vaccination. We know that the best way to curb this pandemic is to vaccinate as many people as possible. So can we mandate vaccines during a public health crisis? And there's a long precedent in this country for doing just that. At the same time, we must consider those who might be exempt from mandates and for what reasons we might exempt them. So historically, there's been two kinds of vaccine exemptions: medical exemptions and religious exemptions. Those who can receive a medical, who can receive a medical exemption and what counts as a religious exemption are always big questions. So if we make it too easy to get an exemption, then we risk continuing this pandemic. But if we don't allow any exemptions, we might be undermining some civil rights legislation. So the medical exemption falls under the Americans with Disabilities Act. There are some people for whom receiving the vaccine would be risky because of an underlying health condition or immune deficiencies that render the vaccine ineffective for them. The ADA requires that employers accommodate a person's disability or health condition, unless doing so would place an undue burden on the employer. So most of the time, accommodating a disability doesn't harm other workers, but in a pandemic, not being vaccinated might put others in harm's way. So an employer could technically deny a worker's request for an exemption if there's no way that that worker could do their job remotely. Now, religious exemptions, on the other hand, fall under Title VII of the Federal Civil Rights Act of 1964, a section of the law that mandates that employers must make, quote unquote, reasonable accommodations for an employee's sincerely held religious beliefs, if doing so does not impose undue hardship on the employer. So interestingly, there are 6 states in this country that don't allow for religious exemptions for vaccines for children. And the Supreme Court just decided not to take up a case in Maine that denied religious exemptions for healthcare workers, meaning employers in Maine are now legally able to deny healthcare workers requests for religious exemptions from taking the vaccine. So in other states, workers must show that their objection to the vaccine truly is based on a religious belief, and that belief is sincere. It's the employer who gets to judge if that belief is truly religious and not some other kind of belief, say a philosophical belief or a political belief, and whether or not that belief is sincerely held. So both of these conditions are really hard to parse out since we don't really have a solid definition of what counts as a religion in this country, and because sincerity itself is hard to assess. Now, an employer could deny a religious exemption if the employee shows evidence that they acted in a manner inconsistent with their professed religious belief, like an employee was fine taking other vaccines, or if there's a reason to believe the employee is seeking an accommodation for reasons that aren't actually religious. So for instance, if they're actually political beliefs that are masquerading as religious beliefs. Again, this is incredibly difficult to discern, and many employers right now are struggling with these kinds of exemptions, especially in healthcare. So currently, COVID numbers in Texas seem to be on the downward trend, which is great, although as Dr. Hotez said, this could change and is changing in other states. So we're definitely not out of the woods yet, and we'll likely be dealing with the fallout from COVID for quite some time. There are two things that I'm hearing from healthcare providers right now. So first is that they're burned out. They're experiencing unprecedented levels of moral distress. Most have been working at maximum capacity for nearly 2 years. So for example, our local palliative care team is carrying almost 3 times their normal patient load with no extra team members. And that's just an unsustainable working environment. And some healthcare workers were laid off or retrained for new roles during the pandemic if their services were suspended due to the need to focus attention on intensive care services. Many others experienced pay freezes at a time when they're being overworked. And many healthcare workers have quit their jobs over the past year, and it's looking like it'll take a very long time before we can recruit and hire people to replace them. So the second thing I'm hearing from healthcare workers is that they have never experienced the levels of anger directed at them from patients and their families. So some of this is understandable. It's an incredibly stressful time for everyone, and with so many dead, it's hard not to be anxious. But something more is going on. I hear this particularly when families are requesting medications like ivermectin that physicians don't want to provide. So what I'm hearing from ethicists all over the state is that healthcare workers are receiving this extraordinary anger at their refusal not to provide this non-beneficial treatment. And this anger, along with their burnout, has made their jobs just uniquely stressful. So figuring out how to care for them is going to be a long-term project for all of us moving forward. All right, so I'll stop sharing for a second. And Lauren, do you have questions for us back and forth?
No, I just wanted to thank you, Dr. Stahl, for your comments. And I think the first question I have, first of all, I want to invite our audience to type questions into chat. And second of all, I know that Dr. Hotez was listening with interest to all the things you were saying. And Peter, I would just like to offer you the opportunity to dialogue with Dr. Stahl a little bit about your comments back and forth while we wait for some questions for our audience.
Yeah, I mean, it looks like, how we manage healthcare and public health is going to have to change, right? I mean, we can't keep on with this level of aggression. The defiance around vaccines and insistence on fake cures, and how do we begin chipping away at this? Because again, this is very much along a partisan divide, and there's no concealing it. So, for me, the big question is, and I don't really know that anybody has got answers. Clearly, the Biden administration does not know what to do. How do we uncouple the anti-science aggression out of far-right politics, out of conservative politics? Because it keeps on getting amplified every night. I mean, if you turn on the conservative news outlets at night, you're just getting rants about ivermectin and fake information about vaccines and anti-vaccine sentiments. And the health system is just can only tolerate so much, and we're already seeing it start to fray or break. You talk to a lot of doctors now in the medical centers, including here, there's just not enough nurses anymore. People are just saying, I've had it. And so the whole thing, I think, is on verge of collapse unless we can figure out at its source, what do we do? And unfortunately, what we get from a lot of our elected leaders in Texas, not only in Texas but elsewhere, is you usually don't hear overt expressions of anti-science or anti-vaccines. I mean, you do from some of the real wingnuts, but that's the exception. What you hear more commonly is some lukewarm statement about vaccines, followed by, but of course everybody's free to make their own choice. Everybody and so all around this health freedom stuff, so that there's this false equivalency built that either you can get vaccinated or you have freedom of choice to get nonsense, to get ivermectin or whatever others, what else is going to be out there. So how do we, one, tear the anti-science out of our right-wing politics, number one. Number two, how do we convince our elected leaders to stop going down this health freedom, medical freedom path? And I think the third area is, how do we create a safe space for academics to talk about this stuff? Because it's very uncomfortable for us, and we tend to, get admonished, or, we're basically told, well, you talk about, if you go into politics, you do it at your own peril. And we're not doing it because we like doing it. It makes us uncomfortable, but, if it becomes necessary to save lives, that's what we need to do. How do we make this happen?
Yeah, I mean, these are all great questions that, of course, I don't have answers to. So it seemed like early on in the pandemic, it was really physicians talking with their own patients that was breaking through with vaccine information and helping patients who were hesitant to get vaccinated. But I think it seems more and more what I'm hearing from physicians is that sort of like one-on-one personal interactions they're just becoming more difficult as people become more intransigent. And so it's very difficult to talk to folks.
Yeah, they're becoming quite volatile, aren't they? And
yeah, that's what I'm hearing, and that these sort of demands for unproven therapies are getting more and more aggressive. And unfortunately, there's been lots of places in the country where judges have sided with these patients. And typically they'll kind of go back on that. But we also need a bunch of people in the court system who understand enough about medicine to not grant these kinds of, or to force physicians to try to give unproven, ineffective therapies to their patients that they know would be risky or damaging to them. So we have a whole system that's sort of failing to support the medical staff doing what they think is right. But
yeah, I'm just worried we're going to, we've already lost 20,000 Texans since June 1 who refused to get vaccinated. I don't see it getting better, and I worry with this next wave, if it's anything like last winter, which was the worst of all, that defiance is gonna double the number. So this is an acute crisis now. I mean, with this massive loss of life, and it's just so heartbreaking. So I mean, obviously we're not on an hour Zoom call, we're not going to get to the answers, but I think these are important questions. And again, I think something like a Department of Medical Humanities at a university like Baylor University is well positioned to start figuring out how we begin chipping away at it. I also, when I've spoken to people in the White House, what I've said is, look, I don't think the health sector has the skill set to even know what to do. But maybe there are. I mean, we put a lot of infrastructure to go up against big threats to our homeland security, right? Whether it's global terrorism or cyber attacks or nuclear proliferation. So there are people who know what to do with these big antagonistic social forces. maybe get some advice from them. And so I've suggested to the Biden administration maybe put together a task force from Homeland Security and Commerce Department, Justice Department, even State Department, because now there's evidence that Putin and the Russia propaganda machine is seeing this as a wedge issue, and he's using it to try to, tear us apart even further and try to, and there's even a term for it now called weaponized health communication being used out of the from the Putin propaganda machine through Russia Today, RT, and Sputnik News. So bringing in State Department even has a role, and maybe bring some of those people together. And Lauren, I would say at Baylor University, similar idea that this is the big advantage Baylor University has over where I am at Baylor College of Medicine, where we're purely, medicine and science. But at Baylor University, you have religious studies and you have theology and you have political science and anthropology and all of the social sciences and the humanities to really bring the campus together and figuring out how to prevent needless loss of life. I think you're in a terrific position to do that.
Thank you, Peter. We have several questions in the chat, and a couple of them have to do with education of people who are positioned against vaccines. And if there are any recommendations or ways that either of you have seen be effective in terms of encouraging people who are oriented against vaccines to have them. If you've seen anything be effective, and what might those things be?
I'll just say a couple of words. Well, first of all, one of the things that I do is I recognize that they themselves are victims of this aggression, right? I saw, when people say they're not going to get vaccinated, they basically have been, they themselves have been victimized by this aggression and anti-vaccine from anti-vaccine groups. And in a few cases, some of these groups are even monetizing the internet to put out some of this. So, you can listen to, there's about a canon of about a dozen different anti-vaccine talking points, which range from the seemingly plausible, such as that, well, they're too experimental and I'm waiting to see, even though they're not really experimental. They've been in development for more than a decade, like our program, or to the crazy stuff, right? That they're putting in microchips into our vaccines and that kind of stuff. And you can, go through, and there's, as I say, I call them about a canon of about 12 of these talking points, and you can go through them one by one. But I've found that it's a bit like whack-a-mole. You knock one down and they'll bring up something else. And so you start to realize that for most people, it's not the specific talking point they're bringing up. They've just decided that they're not going to get vaccinated, and they'll resort to these various talking points. And so it's often not very fruitful to go through them, even though I think you have to try. But for a majority, this is not the issue. There's something else going on. Somehow, to show allegiance or for something, they've decided that they're not going to get vaccinated. And that's the toughest of all, because I can debunk each of the 12 common talking points. And in fact, I've written a couple of articles about that. One was in the Washington Post, another in eClinical Medicine. And so far, I've not found that it resonates. It doesn't seem to have much benefit, but I'd be curious to see, Devan, what you have to say.
Yeah, I mean, it seems like there is a certain population for whom just about nothing is going to work for them, but they've just decided and they've dug in. But of course, the numbers are so low right now, 58% of the population. So I do think there's still some folks in that remaining 40% who might be persuadable, or at least that is my hope. And typically what we've seen for other kind of vaccine issues is that it's really trusted authorities. So it's people that they know, who they trust and find in a position of authority. So it's their physician. And Lauren, I'd be curious if as a physician, you've been able to persuade anybody, or it's their religious authorities. And so this won't work for everybody, but I think there's a role here for pastors as well. And I've seen lots on social media who are trying to debunk some of the sort of religious claims against vaccines. So I think that there's a role for the trusted pastor in the community as well. So physicians, pastors, but I think it typically, when I hear about people being persuaded, it's one-on-one with somebody who's being gentle and explaining and who they already know and trust. And it's probably not going to be the public figures who are going to give them the right kinds of facts that's going to persuade them. But I'd be curious, Lauren, if that is your experience.
I see in the chat here from Jeff Levin, it says we have some brand new population data not yet published that confirm this is a purely ideological political issue. Education and income did not explain this away. It's solely about right-wing political ideology, and solely it appears to be intransient. There will remain a large unvaccinated portion of the population into perpetuity, and so the future of all this endemicity, I'm very pessimistic. And I think the other thing I'm worried about is the spillover to other vaccines. So we're hearing that the influenza vaccine uptake is at an all-time low. I'm also worried about what happens, over the next year or so with childhood vaccinations, and whether there'll be a spillover because we have such an aggressive anti-vaccine lobby and political action committee here in Texas. I'm worried about measles vaccination rates, and are we going to see, historically we've had measles epidemics in winter, spring, and what'll happen next winter, spring? Will we start to see measles epidemics erupt as well? So I think we're in a very dark period. I tend to be an eternal optimist, working on something called neglected diseases. So I agree, we still have to keep trying, really hard. I know the Biden administration is pushing hard on the federal mandates. I don't know how much that'll get us there, because if assuming that we need 80% of the population vaccinated, fully vaccinated to stop transmission, and we're only about less than 60% there, there's still another 20-25% of the US population. That's a lot, right? That's what is that? That's 80 million people essentially. And how far can the federal mandates go? I mean, the Constitution was by Jefferson and Madison was written in such a way to limit federal power. So by definition, you can only go so far with federal mandates, and maybe that'll, at best, maybe it'll get us a third of the way there, maybe. So we're still going to have to find other mechanisms, levers to pull and push.
Along that line, in terms of other mechanisms and tying that in with what you asked, Devan, I was recently at a Texas Academy of Family Practice meeting, an in-person medical meeting, which was socially distanced, but also delightful to see people from, the neck down for once, where one of the things that was talked about was that the number one persuasive factor that changed people's minds was a recommendation from a trusted primary care physician. And so where I'm going with this is, we've just seen the new bill about infrastructure passed in our country. I think an investment in primary care would make a difference. Now, obviously, I am a primary care physician, but I do think that bolstering that primary care all across the country would bolster those communications and connections between patients and physicians that have really been, we're seeing those strained tremendously. And so, the only thing that I've seen make a difference is a physician and a patient sitting down together in a room and talking through what the objections are. And again, Peter, not all 12 of them, but for patients that have, valid, I shouldn't say valid, I should say, specific questions and concerns, having those addressed has changed some patients' minds. Yeah.
Yeah, there's a nice statement in the chat from Diana Gillespie. It says, Dr. I think you might be interested to know about our faith in the vaccine ambassador project on this campus. It just ended, but we used a grant to change the conversation, how to convince people to get vaccinated. I believe we were incredibly unexpectedly effective. The kind of listening coming from all different religions and learning how to effectively argue. It is all a different type of rhetoric than usual. This is the way we got students to actually read our facts and consider vaccination. I'm writing on this project for Interfaith America. I'd love to send it to you once it's published. Yeah, I think that sounds really exciting.
Mhm. Absolutely. Devan, what are some of your other thoughts based on what Peter had to share this afternoon about the direction that he sees things going?
I mean, well, it's certainly alarming, and it's really hard to predict, right? Because we thought after the first wave that things were getting so much better, and I, at least my perception in Texas was, or here in Waco, was that we kind of just pretended like everything was fine in the fall, when then going to the hospital every day, seeing how many people were dying and how overwhelmed our ICUs were. So I do worry about a sort of second spike there that we might experience, and if we're really prepared for that. I'm not sure that we are, and I feel like people are just exhausted with trying to distance and mask, and I just don't know what's really going to get us over this except continuing to increase vaccination rates. But yeah, it's just kind of a quagmire right now. I try to remain optimistic, but I mean, I would want to encourage people that we've seen lots and lots of people in the hospital who are very, very sick, who definitely regret not getting vaccinated. That is sort of what they're expressing. They had the opportunity, they didn't. And many young people, people who, I think a lot of our students here think that they're young and healthy and that this can't hurt them. But we had several patients in their 20s die in our hospitals in Waco, which is just so scary and needs to like sort of be more visible to our
Yeah,
population.
I mean the narrative that's out there, and my friend and colleague Joe Rogan, unfortunately, is put this out there a lot, is that if you're young and healthy and fit and you go to the gym every day, you don't need to get vaccinated, and we know it's not true, right? So breaking that is, and convincing young people especially, because as I say, I think this anti-science aggression is, when you crunch the numbers, will turn out to be the single leading killer of young adults in the state of Texas, and probably other parts of the country as well. And so, I mean, that's, if I sound sort of strident at times, it's based purely on that, that to see what we can, because it's not ending. This next wave is coming, and losses in life will continue.
I want to jump in here. My colleague and fellow family physician, Dr. Charlie Stern, put a comment in the chat that affirming patients' confusion and anxiety around the vaccine and then offering to answer their questions. And I think that is an important thing, to just affirm the confusion and anxiety around it and just acknowledge it before jumping in and trying to make your case. I mean, everyone's experiencing anxiety and confusion, including healthcare professionals, right, Peter?
Well, the messaging coming out of the White House has been pretty bad, especially around the boosters. And one of the things that I've been saying since January is that the mRNA is a 3-dose vaccine, and based on the fact that the first 2 doses were given so close together, you bought ourselves a 3rd dose, and then it's going to be fantastic in terms of the levels of virus neutralizing antibody. The problem was I was only one of the few saying that, and you had, for instance, the CEOs of the companies were spectacularizing their responses in order to jack up the stock prices, and the messaging coming out of Health and Human Services agencies was very muddled and very confusing. And you saw even some marked differences in opinion of what the goals of vaccination were at the FDA advisory committee, CDC advisory committees. And so transparency is great, but people looking at this saying, what the heck's going on? And so that, no question, that has contributed a lot to people worried about getting vaccinated. So I think Dr. Stern's absolutely right.
Well, we're at the end of our time together. I want to thank Dr. Hotez and Dr. Stahl for this conversation, for the first annual DeBakey Lecture in Medical Humanities and Bioethics. And obviously, it's difficult to come to some thrilling conclusion because of the situation that we're in. But I, for one, have really appreciated the nature of this somewhat informal exchange as compared to sort of more formal Zoom webinars. We really appreciate both of your expertise. I'm glad for the two of you to meet via Zoom today and look forward to more and more dialogue. Thank you all for being with us this afternoon. Look for the recording that'll be posted on the Bioethics Initiative website here at Baylor University. Have a good afternoon and a happy Thanksgiving, and don't forget to get vaccinated. Bye-bye.
Thank you so much.
Thank you, Peter. Really appreciate you being here. How many Zoom meetings were you on today?
I don't even know, but this is so important because, again, just focusing on the biomedical model and having docs talk to each other, we already know that's not going to work. We need this kind of interdisciplinary expertise, like the type you've brought together today, Lauren. So this will be an ongoing dialogue, I hope, because we're going to need more of it.
Absolutely. And I wanted you to know too about Dr. Stahl's Bioethics podcast. Bioethics for the People. Isn't that a great title?
Love it. Very important.
Yeah. So, all right. You all have a good afternoon.
Thank you. Nice meeting you.
Okay.
Devan.
Bye-bye.
Bye-bye. Bye.